So, dear colleagues, dear guests, I would like to welcome you in the European Parliament and thank you in advance for your valuable contribution to following discussions. Some of you may already be familiar with the fact that I did not start my career as a politician, but as a doctor. I finished the med school in 2016 and I spent 2 years as a psychiatric resident and then 6 more years as a surgical resident doctor in the Hungarian healthcare system. During my practice, I've experienced, seen, and worked a lot with my colleagues. And what I learned is that being a doctor, surgeon is not only about skills, knowledge, and responsibility. If somebody wants to become a doctor, he or she should learn how to communicate with patients, adapt to changing working schedule, make serious and responsible decisions quickly, and also find ways to spend quality time with their loved ones and allocate enough time to recreation. And we all know that maybe this is the hardest part. This profession teaches you how to help people in urgent need, to inform the patient properly, to conform them in the most stressful moments, and guide them to make informed and calm decisions about their health. Being a physician is understanding patient needs, being able to carry out complex differential diagnostics, plan treatment, and execute in teamwork. Because healthcare is about teams, and physicians are mostly team leaders in these teams, and it is a big responsibility. But this patient-centered teamwork needs time and resources. Unfortunately, we experience alarming trends in the number of healthcare professionals in Europe. According to WHO data for 2024, there is currently a shortage of around 1.6 million health and social care professionals in Europe. And by 2030, this could reach 4 million with a predicted shortage of 600,000 doctors. In Hungary, we have around 40,000 shortage of nurses. Almost 1,000 GP practices are not occupied, making it difficult for nearly 1.5 million people to access to primary care in their own neighborhood. The phenomenon of brain drain has a particular effect on Central and Eastern European region. Healthcare professionals' migration from the rural area to capitals and from eastern part of Europe to western part of Europe has devastating effects. Rural hospitals are emptying, departments are closing, posing enormous difficulties for patients living with chronic diseases and with a need for regular checkups. Although the COVID-19 pandemic has silenced, healthcare systems haven't managed to recover fully from it. Postponed interventions, lengthened waiting lists, exhausted nurses and doctors are clear signs of prolonged recovery. On the workforce issue, we should act now. With the joint EU report on healthcare workforce shortage, the Parliament should urge the Commission to take immediate measures to stop the current trends while establishing a long-term strategy to tackle the workforce shortage all around Europe. The aim is common: to provide accessible and affordable healthcare for all EU citizens with a sustainable workforce management while respecting the member state sovereignty. Take a big step towards that aim with this high-level event with professionals for all over Europe. I think maybe we can find some solutions and together we can move this very important issue forward, because if we don't act now, we'll lose not even more healthcare professionals, but also patients. And our duty is to save the patient's life in European Union. Thank you very much.
Good afternoon. Also from my side, I'm very happy to see so many people and to see so many doctors and their teams here. I'm not a doctor. I'm only a psychologist, but my father and my brothers are doctors. So it was always a topic that we discussed a lot also at home. I think also it's the first time that we have so many doctors in the European Parliament today. So I'm pleased that we can look, as already said by András, for solutions to problems faced by doctors and also with doctors. And of course, I could also just discuss now with my colleague Kulja, who is, as he said, a doctor himself, but having over now 30 medical association here is quite an achievement. So thanks really to the CPME for bringing this event to life. And we are all aware of the healthcare challenges that we have. And so I do not want to repeat what we all know already, and also to leave as much time as possible for the discussion afterwards. So I would like to mention the consequences of healthcare workforce crisis that we have throughout Europe. So we know it is a declining then also of quality of care. Of course, it is linked to that. It was already mentioned, also longer waiting times and reduced access for patients and worsening also health inequalities, increased cost for health system, and finally, mental and physical strain on healthcare professionals. So we agree it cannot continue like this. There are challenges that are best addressed at the European level. There are even challenges that can only be resolved at European level. So I come from Luxembourg, a country with the greatest shortage of doctors in the entire European Union. So I think it's important to say, as we often assume that the problem is only an issue for poorer countries. In fact, all countries face the same issue, whether rich or poor. To address this issue and to find solution, we need more cooperation and not more competition. So let's talk and then implement what we discuss here today. Thank you very much. So maybe now the people for the first table ronde, for the first panel. So it's András and then Dr. Martin Balzan from the Medical Association of Malta, Dr. Ina Kelly from the Irish Medical Organization, and Dr. Nicolae Branzalov from the Bulgarian Medical Association. I call them to come up and I'm going to listen closely.
Patients need a healthcare system that has enough doctors to meet their needs.
In the Czech Republic, doctors are currently facing a lot of problems, especially shortage of not only doctors but all healthcare workers and their uneven distribution. Especially in some rural areas, some hospitals or departments are massively understaffed.
There is a restricted time for consultations. There are problems with the referrals to specialist consultation of the patients because of lack of specialists in some areas.
In Greece, there aren't enough GPs, and they are paid significantly low for the workload involved.
Many doctors prefer to work in private services because they get better wages, better working conditions in general.
Unsafe staffing levels, impossible workloads, and even violence against healthcare professionals are driving them away. This is leading to a public health crisis. We do need urgent action.
Yeah, good afternoon, ladies and gentlemen. Here's the echo again. Is there an extra fee for the echo? Honored members of parliament, thank you for having us here and welcome to our journey to solutions for the European health workforce crisis. It's a little bit a journey with a plane. Like coming to the airport, you need to be there early, going to ticket control and safety check, and then you have the boarding process. And when there is a delay already, when you are in the plane, then the pilot promises to fly a little faster to reach the destination in time. So thank you for joining this discussion on the shortages of doctors in Europe. Across the continent, we are witnessing a growing crisis. A lack of investment in healthcare systems has led to a systemic strain, further exacerbated by the SARS-CoV-2 pandemic causing COVID-19, which delayed care, yielding in unmet medical needs and increased the workload for already overstretched doctors. Adding to this, many doctors are approaching retirement. Alarmingly, we are also seeing doctors leaving the profession altogether or moving abroad, as medicine becomes less attractive as a lifelong career. We have shared policy messages for many years, but we see that while everyone agrees on the problem, there is not enough progress. Today, we wish to bring doctors' voices to policymakers firsthand. We are therefore pleased to welcome CPME members to the panel, and they have already been introduced. So I can start with the first question. That goes to Dr. Nikolai Brancerov. And we wanted to ask you that historically, Bulgaria has faced immigration of a large number of doctors leading to shortages. And what trends do you observe here and what root causes do you identify?
Thank you very much for the invitation. Dear colleagues, I'm very glad to see you here all together and to share with you what we established in Bulgaria. I'm very glad that in CPMA community, they know already this, what is the situation in my country, but it's very good when we are all together here to discuss about this problem, because the problem with in Bulgarian is very serious already. The aging medical workforces in Bulgarian, combined with the increasing immigration of healthcare professionals, they has created significant challenges for medical practice, leading to disparities of healthcare access and service availability. While the total number of doctors in the country has increased over the past decade, this growth has been unevenly distributed. In 13 regions in Bulgaria, more than half of the doctors are over 61 years old, with specialties such as pediatricians, infectious disease, facing severe shortage due to the retirement of the vast majority of practitioners. The average age of practicing doctor in Bulgaria is 53 years. And within the next decade, half of them are expected to leave the system. This results in a lack of continuity in patient care, increased workloads for remaining physicians, and growing difficulties in providing adequate healthcare coverage, particularly in rural areas, of course. The situation worsens as young medical graduates continue to leave. Despite approximately 1,000 doctors, in Bulgaria we have 6 medical universities, graduating each year, between 400 and 500 choose to leave the country or the profession altogether. This loss prevents the natural replenishment of the workforce and leaves medical practice in difficulties to recruit and retain staff. These workforces storages manifest in executive workloads, longer working hours, and an increasing administrative burden on the physicians. Many specialists are very attractive for young physicians, such as oncology, cardiology, endocrinology, while other specialists like pathoanatomy and anesthesiology, for example, are not. General practitioners, I am general practitioner in Bulgarian, are particularly affected as their work is regulated by more than 20 institutions and regulatory bodies, adding to their bureaucratic loads. Despite the introduction of e-health system, papers work remains a significant challenge, making it difficult for GPs to provide care for growing patients list. Addressing these challenges requires a total strategy beyond financial incentives. We have been advocate for legislative amendments that make continuing medical education mandatory. This initiative will motivate physicians, but also require authorities to remove any administrative or logistical barriers. Future regional development, improved working conditions, and approach to the valuing medical labor are essential. The Bulgarian Medical Association has proposed a framework to ensure fair and competitive salaries based on specializations, experience, and regional needs. However, without significant policy changes, including the implementation of national health map to guide healthcare planning and investment, the aging workforce and continued immigration will continue to threaten the stability and accessibility of Bulgarian healthcare system. Ethical international requirement of physicians is another critical aspect of this issue. While the European Union's four freedoms are fundamental, large-scale migration turns countries into donors for physicians and nurses, while rich countries become recipients without any investment. Thank you very much for your attention.
Thank you. Yeah, workforce drainage is certainly a problem, even or especially for countries like yours. I remember that 12 years ago we had a CPME meeting in Romania, and at that time was told there were approximately the same number of doctors already working abroad than still working in Romania in the public health system. I'm not close to the mic probably. The next question goes to Martin Balzan, and it reads, various countries have implemented measures such as expanding medical training, fostering international partnerships, and adjusting workforce planning to address shortages. One of such countries is your home country, Malta. What have been the successes and the limitations of these approaches in improving retention and sustainability of the medical workforce?
So First of all, thank you to all and the current CPME Council for inviting me. I also thank Christian and the previous CPME Council for giving me space to work on this topic. Now I will speak about Malta. I became General Secretary of the Medical Association of Malta 24 years ago in the situation which was described very clearly by our Bulgarian friends. And my idea is to bring a message of hope. And what did we do in Malta to turn the tide or to reverse the downward spiral into an upward spiral? And the first thing we asked the doctors, why are they leaving the country? And they said, money, the salaries are low. They said, working conditions are bad. There's a whole session on working conditions. I will not overlap with the other sessions, but they told us we want high quality postgraduate training programs. They also told us if I am to stay in this country, if I study and have these high quality training programs, then I need to progress in my career. That means I get a job where I practice as a specialty. And we changed from a pyramidal system where you had one boss and a lot of assistants to a more horizontal system where you have, when you're a boss, you have one or two assistants, which are usually trainees, and most specialists progress quickly to have their own autonomous practice. So I actually convinced the government to put his money where his mouth is. So to create structure, the salaries went up. So I can tell you, today I earn probably 5 times as much as I was earning at that time. And our salaries are, to the extent I did not give them to FEMS, because our government told them, don't give them to other countries, because we will have trade union problems here in Malta. So high salaries are part of the game. But the quality of life and the work-life balance is also, but as you've seen in my clip, whatever problem you face in a small department, in a big department, in a big hospital, in a big country, in a small country, the number of doctors in that institution is critical to the service you provide and to the doctors staying there. So the government put a lot of money with, of course, the medical association barking down his backside, all right, to develop, and we actually got European money. This is something which gets a lot of training where there's a problem. So, but you have to be wise enough to put it in the priorities of the country, of the relative funds. So we got a lot of European money, a lot of local money, got loads of experts. Since we are very close to the UK, we built our system on the UK system. We think it's one of the best, but it's very similar to our traditions. And I always told we will never compromise on quality. We owe our doctors the best education. We owe our patients the best doctors. So, and you would think, making training long, difficult with exams is counterproductive. No, the young doctor is proud of his profession and he's proud of the treatment he gives to his patients. Of course, once he does all that effort to get that education, he wants to give back to society, he wants to make money like everybody else, and he wants to have a family and children. I'm saying he. Now, I have to say she, because in Malta at that time, there were very few women. Today, there are more part of this process of getting more people into the profession. Today, there are more women in the profession, not yet the same amount in the consultant specialists, but they're coming up, gradually replacing the people who are retiring. So the people at the bottom coming up are replacing, the women are replacing the men. So my message of hope is that ask your own doctors what they want. Money, usually for governments, doctors, service to patients is votes, equals votes. You understand? Your problem is convincing the government to find a way how to give it to the doctors and not to the others. But they will always find money, especially when you link it to education. So a lot of our pay rises are, if you are a trainee, you get training allowances. And as you progress in your training, that allowance gets bigger and bigger and bigger. Once you are specialized, you become a trainer. And as time goes by, the trainer's allowance goes up and up. So you are being a trainee and studying and progressing linked to your salary. Once you become a trainer, it's not an automatic payment part of your salary, no. If the trainers, the people in charge of the training, don't think you are delivering, they might take it away. And then the whole structure of training, there is departmental, there is bigger departmental, there is regulatory. So the training structure created a lot of opportunity to create pay rises, which are justified by the level of academic achievement, by the level of, even if you do research and publish papers, you get what are called merit awards. So if you link money with quality, for population, for the politician, you are linking money to population, to patient satisfaction, to voter approval. Their problem is, why should I give it to the doctors and not to everybody else? So to cut a long story short, there is hope. And it took me 4 or 5 years to convince our politicians. So even though I started 2004, I started seeing some listening from the politicians in 2007. To conclude, the question which is most often asked at European level is, how many doctors, if you say not enough, how many doctors does a country need? And unfortunately, the data collection is not standardized, and healthcare systems are not the same across countries. So I would ask for more standardization across the EU countries on data collection. We need to know not the people on the register, but feet on the ground, full-time equivalents. It's if everybody is on part-time or doing double the time. So, and finally, and anyway, the end result has to be the doctor is happy, he has work-life balance, he has career progression, and the patient has a service for which he is satisfied. I repeat, the number of doctors in the country is key. So from our experience in Malta, I think you need at least 4 per 1,000 population, but that's based on our little test tube. It might not be applicable across Europe. Thank you.
Thank you, Martin. So we can eventually summarize: pay your doctors well, treat them well, give them satisfying work to do, and they'll then do it. The next question goes to Dr. Ina Kelly, and we wanted to know what specific challenges you face in recruiting and retaining the younger doctors, and if there are additionally gender-related challenges.
Thank you very much, and thanks for inviting me to be part of this panel as well. I think we all agree that doctors want to do high-quality medical work to protect lives and improve the lives of their patients. And one of our problems in Ireland, I think, is that we target our recruitment too low. We have minimum levels that we're trying to achieve, and we're way below those levels. And we have a growing population and an aging population. So even the minimum levels that we're looking for are probably too low in their own right as well. So it's interesting what Martin's saying about how many do we need? And I think we're probably aiming too low. And even at that, we're not really aiming, we're not implementing. So say, for instance, with general practitioners, our family doctors, or in primary care, we haven't, as far as I'm aware, we have not increased the number of GPs with state contracts over about a decade, despite the fact that we've had a massively increasing population during that period of time. And this puts every general practitioner doctor under terrible stress to try and provide the service that they need to their patients. So that's the same happening in the hospitals with the hospital specialists. Is again, we're about 2/3 of what our minimum requirement, which was based some years ago, again, probably too low. And so what we're dealing with is everybody's working under overwhelming demand and not sufficient resources themselves to provide that service at the high quality that they're expected to provide and that they want to provide. So it's really important that we actually start targeting our recruitment at the right level, because otherwise it's a vicious circle of, I don't want to work in that space. I can work somewhere like Australia or somewhere where they have enough doctors and I'll be able to have a decent life, and I'll be able to provide high quality service. So that's one of them anyway. The next one then is the tools really that we use to do our work. As doctors, we don't work alone. We work with teams and we work with other investigative procedures and services like diagnostics. We need inpatient beds. We need clinic and theatre space in hospitals. And we need to try and deal with backlogs of patient care. We need to prevent those backlogs occurring. We need to have an awful lot of administrative support to get those sorts of things working right as well. We need our full multidisciplinary teams with all the allied healthcare professionals working with us to share out the work too, and not to be placing all the burden on existing employees. And then we also need our infrastructure in IT to work properly as well. And we are very slow in Ireland to get the electronic health records. I think they're very good in general practice, but they're not very good in other parts of the service, the health service. And all of those things impact on our efficiency and the quality of care we can provide. So we are struggling day after day with frustration, overwhelming demand, and so on. So we need to have the right recruitment, we need the tools, and then of course the doctors who are working and training in this area, they see all of this. They don't want to work in this. They see Ireland as being too difficult to work in, and we know that around a third of them who are trained in Ireland are choosing to emigrate for the longer term. And, you know, Irish people, we speak English. It's easy for us to get jobs in English-speaking countries, of which there are a number of jurisdictions where healthcare is better resourced, and there's a better work-life balance. And once some of your friends go abroad and you hear about it, off you go yourself as well. And then you may not come back. And we know that the numerous studies, we've had very good work from the IMO and our CSI and others, showing that, you know, insufficient resources, the staff shortages, the deteriorating working conditions, you know, infrastructure, lack of opportunities for career progression, and the poor work-life balance and burnout. Burnout is a normal part of a doctor's life in Ireland. If you're there for not very long and you start getting burnout. And so all of these drive emigration to other English-speaking jurisdictions mainly. And therefore it's just something that we live with on a day-to-day basis. So we really need to turn that corner. Now, for instance, though, say recently with junior doctors, they're routinely working more than the average 48 hours a week of the European Working Time Directive. I think 70% of them in a recent survey. And this is inherently unsafe for patients and for the doctors themselves. And while over half have been rostered for a 24-hour shift on more than one occasion. So we have this sort of lack of effort to put into actually make the working conditions right. And I think a lot of that, again, is targeting recruitment too low, not providing the progression that's required, not providing the ancillary tools that are required. And then, of course, there's the gender related issues as well. Insofar as I think, though, I mean, improvements that are provided to improve the life of women in medicine, mainly that's where a lot of the challenges are. They improve the life of all doctors, and doctors of you know, men and women are all wanting better quality of lives nowadays, and younger people are looking for. Their expectations have improved, have changed from you know, that very sort of martyr doctor of the past, and they want something better than that now. And so the sorts of things that really need to be in place are, we're asking people to work very, you know, 24/7 and all of that, but they don't have supported childcare and on-site childcare, and that's one of the biggest problems for our staff. And women doctors are more likely to choose family-friendly specialties, so they make their career choices based mainly on the fact that they may be able to have a family, and that is unfair. That they're not really you know, that they're being pushed into areas that they may or may not have been interested in because of the fact that the service is designed for a past, but it's for the distant past, and it hasn't been redesigned for modern times. So it's important that we improve our recruitment, our tools to help us to do our work, and we need to make the experience of doctors much better in Ireland. You know, we work for a very long time training. And like our training is 15 years on average, and you need to, during that period of time, we need to make people want to stay in Ireland so that we can hold on to them. I think that's enough.
Thank you. With respect to the timetable, we do a kind of speed dating. So my wish would be that the next question everybody tries to answer within 1 minute, more or less. And the question would be, It's not fair, I know, but this is the most important sentence is the first one then. We have been already trying to improve data on the workforce to better be able to identify and map shortages. And the question is it useful? And what is your experience in how data can be leveraged in tackling health workforce or shortages? So everybody tries to answer this question within 30 to 90 seconds, please. Who wants to start? Martin, is this the question?
So
you already
so data on I think so different countries collect data differently. So the most important point, at least when they ask us at EU level in EU institutions, what are your suggestions, is that it has to be standardized, that everybody is collecting the data in the same way. But the bottom line is, from a practical point of view, I speak for my department, I want to know how many feet on the ground, hours of doctors I have available. So you need to know the number of full-time equivalents of people actually working. So women get pregnant, they have children, there are reduced hours, there's part-time work for people who might have personal problems. We have all of those in Malta, but to have all these rights, I don't call them privileges, you need to have enough doctors, because our patients and our colleagues should not bounce neither on the patients, neither on the colleagues, that somebody is getting his rights. Just the other thing is, I repeat, there is no standard how many doctors in a country are enough. Now, we in Malta have enough doctors, but we have areas of surplus and we have areas of deficit. So you need internal planning, that when the trainee posts are issued, that you think the planners know where they have deficiencies, where they have too much. Thank you.
Thank you, Martin. Who is going to continue?
Will I say something? Just good data is essential for workforce planning. And I think what Martin was saying about standardization of data is essential, because we need comparative figures and to learn from each other. But obviously, when we're comparing data, it's often being misinterpreted. So it's actually not useful at all. So it's really important that the data is the same, and we need to understand each other's systems so that we can align our data to understand what's happening. And I think it's just because I think in the long run, you can't improve, you can't diagnose a problem. And this is a problem that needs to be diagnosed and can't be diagnosed properly without accurate and, interpretable data. Thank you.
Thank you. Dr. Branzalov, you share this position?
Yes, I'll say a few words about when we have a shortage in any country. Bulgaria is not the exception. We have to find cover these shortages. When the doctors are less than is necessary, because you know how many doctors in Bulgaria more we need. But when we are short, we have two ways to found them, maybe three. First one is to have no more medical graduates. But I share with you the number, how many of them left. So to stay in my country, they have to be, they must be sure that they will work in good condition. For the moment, it doesn't happen. Also, Bulgaria is a country, I'm sorry that I'm talking for the moment only for Bulgaria. When our society already by habit from the previous system, they exist more than from as medical skills, as access from the doctors. Still, our society cannot understand the doctors in Bulgaria are on shortage. So, as example, in my country, any patient, our citizen, if he decides to visit doctor in the same day, he will do it. If this doctor, for example, that usually is a general practitioner, decide that this patient needs a specialized, in the same day, it's possible. We can realize. If the specialist or general practitioner decide that this patient needs a hospitalization,
So we need a kind of steering
but
to meet the
let's
real
have to
needs.
think about, is it like this in your country or not?
Yeah.
Thanks very much.
Thank you. That's a problem we have in many countries. Now, once again, thank you for having us here on this health topic, and what we wanted to ask, especially you as a parliamentarian, that there are many voices, of course, in Europe that says it is not a European topic and should be dealt only with on the national level. And what would you respond to this position?
Thank you. First, if I may, I would like to jump back to the data. I think the data is crucial. When we examine a patient, we collect data. When we check their test results, we collect data and we make our decisions, create the diagnosis based on that data. So to find a diagnosis for our healthcare system and find a solution for the workforce shortages, we have to have good quality data as much as we can and analyze it properly, and also analyze the health conditions and challenges among the citizens. And that's why it is very important that we all have the European health data space, because that's how we'll have a structured and the type of data that we can analyze and share, and together maybe we can find solutions. And yes, managing the healthcare workforce was always a member state competence. But on the other hand, since the EU has made the free workforce movement a reality, the phenomenon of brain drain and workforce migration became a notable issue. And please don't get me wrong, I believe the free movement of the workforce is a wonderful achievement of the Union, but I also believe that we have to deal with the consequences as a union as well. Because due to the fundamentum of subsidiarity, EU can make only regulations if the member states are not able to do it better on their own. But I think the COVID-19 pandemic showed us that together we can make better decisions and find better solutions. And instead of competing with each other, working together, we can find solutions. And that's why we have a European Health Data Space, why we have a Critical Medicine Act, because the European Union realized that we face the same problems in every member state. And yes, there are richer and a bit poor countries in the European Union, and we see that workforce shortage is a much bigger problem in Central Eastern European region, but we see the same symptoms in Western part of the Union because of the aging population of the medical workforce. And if we don't try to find a EU-level solution, that we lose time. And we all know that to have a good and well-qualified doctor is not only 6 years as a medical school, but also the time of the specialization and after it, because you learn until your retirement in this profession. And because of it, I think that we should deal with this on EU level. And today there was a hearing of Commissioner Varhelyi in the SAND committee, and I'm very happy that we have a SAND committee as a standing committee here in the European Parliament. I think it's a very important step. And I also raised this question that what can the EU and the Commission do? And he acknowledged that it is a very important challenge issue, and yes, it is mostly a member state competence, but he agreed that we also have to work on EU level to find good solutions. So yes, it is not an easy task, but and just two more things, if I may. You see that it is really hard to find good solutions for rare diseases because they are rare, affecting 30 million citizens in the EU, but they are very different. And in the smaller member states, there are only very few patients, and to give them the proper treatment is sometimes really hard. And the question is that it's better to send the treatment and proper care to the patient, or the patient to the center, which is specialized. And I really think that we'll face this problem in cancer treatment, autoimmune disease treatments, because the therapies are more and more specific, personalized. And at the end of the day, every cancer will become a rare disease. And we have to prepare our healthcare system and also our healthcare workforce. And to find the solution, we have to analyze the different layers. And even we have the most modern therapies, without workforce, without doctors, we cannot give the therapy to the patients. We need the healthcare workforce. And I think in this mandate, this will be a very hot topic here in the European Union. And I talked to many other MEPs, and all of them are very committed to work on this issue, because we see that actually to secure the society and the health in the European Union, it's crucial to find a solution for the shortage, to secure that level of life what we live now, and that health security to patients. So yes, it is a member state competence, but I think now we all realize that we also have to work together to find the proper solutions. Yeah.
Thank you. So this is very good closing statement for this panel, and thank you for your dedication for this topic. And then we see 2 other videos, as far as I know. One, only one. Okay. I thought 2. And then we need to change panelists.
Some of my colleagues wish to leave the healthcare profession because of number of reasons, but most importantly, the struggle to keep the work and life balance.
Många läkare tycker också på familjebildningen för att inte halka efter lönemässigt med föräldraledigheten.
Healthcare systems should adapt to allow colleagues work part-time and provide that leadership and existing skills.
Currently, 38% of our workload consists of administrative tasks, including retyping existing information. And as the population grows and ages, this issue will only worsen.
In the rural hospitals, it's usually hundreds and hundreds of hours over the limit. And of course, there are problems with salaries because some doctors are heavily dependent on the money that comes from the illegal overtime hours.
I see doctors who are overworked, burnt out, and considering leaving the profession. Not because they lack passion, but because the healthcare system is failing them.
I barely remember a week during my residency, which lasted 8 years, that I worked less than 83 hours weekly, of course, apart from holidays. As you know, these working circumstances affect our well-being and personal relationships. We need protection and respect.
So, hello everybody. The new panel is put together from our other host, member of European Parliament, Metz, the representative, CPME representative of the Czech Medical Chamber, Dr. Milan Kubek, our CPME Vice President, Dr. Kitty Mohan, from the British Medical Association, from the Medical Chamber of Slovenia, Professor Bojana Bejovic, and last but not least, Dr. Philippe Catala, the representative from the French Medical Council. Welcome, and thank you for joining the discussion on the working conditions of doctors across Europe. Addressing working conditions is the most important preventive measure to ensure quality of care and patient safety. Maintaining the attractiveness and of the medical profession and minimize psychosocial risks that threaten well-being. While salary is often, and we have heard about this, at the forefront of discussion of retaining doctors, other factors such as staffing levels, workload management, and professional support also play a crucial role in maintaining and a motivated and sustainable workforce. Across Europe, doctors are increasingly burdened by excessive working hours, insufficient rest, and escalating administrative pressures, which limits their ability to focus on patient care. The pandemic causing COVID-19 has not only intensified these issues, but it has also highlighted the urgent need of safeguard the well-being of our medical professionals. So we have a few questions prepared, and the first one, in that case, goes to the Member of Parliament. We have we seen the video with the working conditions? Yes. What specific policies or initiatives do you believe the European Parliament should prioritize during its mandate to address the challenges and improve the working conditions of healthcare professionals across the Union?
Thank you very much for that question. And indeed, there are things we can do at the European level. Today, what we really face, and the undeniable truth is our healthcare systems are under immense pressure, and the backbone of this system, our healthcare professionals, are bearing the brunt of this crisis. That is the reality. What we have is deteriorating working condition. We have also growing violence happening. We have staff shortages that was mentioned a lot, not only of the doctors, but in general. And we had insufficient support. And all this is pushing doctors, but also nurses and caregivers to their really utmost limit. So we cannot just stand by as European politicians and watch this continue. It is time for bold and decisive action. We did that also during the pandemic crisis. If there we would have only sticked to what is our official competence, we would not have had a vaccination for the 27 countries. So I am happy to say that this parliament is taking it seriously, and I am taking it seriously, and we are kicking off the work on a special report that will address this crisis. As András said it, we're doing that in the Sant committee, but of course this will then also be discussed and the plenary, and that was already a topic also there. So we have this special report on the healthcare professional crisis that we face, but then we have also on the level of the Commission is already doing it, or also addressing the topic to the Union of the Skills and other relevant legislation. Commissioner Minsatou presented in Strasbourg in February when we had a debate on this very topic. She was making the link to the Union of Skills that we need. So, and of course, I cannot speak for the whole Parliament. I can tell you what are my priorities, and I know that's also András and other people from the Sun Committee priorities. Firstly, yes, of course, we need better working conditions, fair pay, continuous training. We need to reinforce also the social dialogue with the doctors, with the healthcare professional. We need to promote collective bargaining and really ensure that healthcare workers' voices are heard and that the needs are addressed. So it's about pay, it's about professional deployment, it's about protection from violence, must be central to this dialogue, especially in regions like Southern and Eastern Europe, where conditions are particularly restrained. So, and the EU needs also, of course, expand funding to improve wages, upskill workers, and make the healthcare profession more attractive and more sustainable. Secondly, We need occupational health and safety. This must be really addressed. We need stronger enforcement of existing health and safety regulation to protect healthcare workers across the EU. I mean, I always say it was very nice during the pandemic to have all those people clapping on the balcony, but now that is not enough. I mean, it was nice, but now we need also legislation that support the working conditions. It is essential, therefore, to develop directives targeting the psychosocial risk and musculoskeletal disorders, also key drivers also of the burnout and staff shortages. Furthermore, we must explore the creation of a directive on safe staffing, ensuring adequate personnel levels for both patient care and staff well-being. And certainly mental health. This is something that is mentioned a lot. For farmers, we speak now also about mental health, but we need to talk about this also among healthcare workers, and we need immediate attention to that. So we should therefore push for a dedicated EU directive on psychosocial risk at work and to address also the emotional toll of these very demanding jobs. This should be done in partnership with social partners as called for in the European Parliament resolution that we had in March 2022. So let's ensure that caring for those who care for us becomes a priority. And then last thing I want to mention, we need and we cannot ignore anymore the threat of privatization and chronic underfunding of healthcare system. Public healthcare systems are the bedrock of equitable and accessible care. We must close the underinvestment gap by leveraging all available EU funds and in this and in the next MFF, from EU Health to Horizon Europe to Recovery and Resilience Facility. I was happy to hear, I must really say it, to hear the Commissioner Vaheli say today, this morning in the Sun Committee, that he will fight to get the money back also for the EU for health, the money, because it's always there where they take it when they need it. So health must not be treated as a commodity. The WHO Europe's called to shield also healthcare from austerity measures should guide our economic governance policies. So, because I always say, when we speak about defense, when we speak about security, access to healthcare is also part of security. Another thing we need to embrace is digitalization, but responsible and sustainable digitalization, not in a way that it gives more burden to the staff, but that it supports staff, that it makes life easier. So digital tools can improve work-life balance and patient care, but only also if staff receive the proper training. So also there we need EU funding. And I say it again, European cooperation is crucial. We must coordinate workforce planning and staffing strategies to avoid harmful competition between member states. Retention policies, faster recognition of qualifications also for migrants and refugees and asylum seekers, and better access to education and language training are also key steps here. Additionally, governments and European Commission should be required to report on coordinated action and investment to tackle staff shortages, ensuring transparency and accountability. That's what we need to do. Finally, and I finish really there now, prevention is better than cure. Promoting longevity and preventive health care will alleviate the burden also, of course, on our healthcare systems in the long term. So healthier population mean also less strain on doctors, nurses, and hospitals colleagues. This is more than just a discussion or a nice policy discussion. It is really a call to action. Our healthcare professionals deserve it better. You all deserve it better, definitely. Thank you.
Thank you. The next question goes to Kitty Mohan. Your colleagues, the doctors in the UK, have done the, I would say, unthinkable in the past. They have undertaken significant industrial action, including strike in response to deteriorating working conditions? And what challenges do they face in accessing and maintaining safe working conditions?
Thank you very much, Chair, and thank you for having me back. It's been many years since I've been back in the European Parliament, and I'm delighted to be here. Perhaps one day we will fully, as a country, be back with you all. We can only hope and wait. Yeah. I think, as Andreas said, we have had many instances over the last 10 years of industrial action in the UK. And this is unprecedented. No doctor wants to strike. UK doctors and doctors in England do not want to strike. It is not that we are more militant or more wanting to do this. It is very much a sign and symptom of what we have faced, and the fact that doctors feel that they have run out of options. Our resident doctors took 44 days of strike action between March 2023 and July 2024, sometimes striking with our specialist doctors. And before that, the last strike action was in 2016. Our resident doctors are understaffed. They are not able to access proper breaks. They say that they tell us that there is no safe way to be able to travel to and from work out of hours. Things are getting dire in the UK. So our General Medical Council runs an annual training survey, which almost all resident doctors in the UK, as well as their trainers, fill in on a year-by-year basis. Last year in 2024, 63% of our resident doctors said that they were fearing high or moderate risk of burnout. This is higher than during the pandemic. They only reached levels of 50% during the pandemic. It is even higher now. It is even more striking that our senior doctors have also been in dispute and remain in dispute in some areas with our government. Our consultants or our specialist hospital doctors took 11 days of strike action between July and October in 2023. This was only the first time that there had been industrial action since 2012, and the second time since 1975. In a survey last year by the Royal College of Physicians in London, Edinburgh, as well as the Royal College of Physicians and Surgeons in Glasgow, surveying the physician workforce, the doctors told us that they had overwhelming workloads, that they have poor IT systems, that they have widespread vacancies, and that they have, perhaps unsurprisingly, very decreased job satisfaction. Nearly 40% said they had excessive workload, and almost 20% of our most senior physicians said that they are almost never in control of their workload. This is stark. The other one of the most important factors is that general practice or primary care in England is in crisis and has been for many years. This is because of decades of underfunding of general practice in the UK, combined with rising running costs for general practitioners, making it harder for practices to hire the staff that they need. It is not just related to strike action, though. We need to think about the pressures we put on doctors as well. Our trainees in the UK, our most junior doctors, face what can only be described as a lottery system to acquire their first jobs in the UK. It used to be 20 years ago when I qualified that if you worked hard and if you ticked the boxes in medical school, you could pretty much predict where you would have your next jobs. However, now it is literally a system where people can be put to work anywhere in the country for the first years of their work, far away from all their support systems. We need to think about the fact that our doctors are humans, they are people as well as doctors, and in order to get the best out of them, the best for our patients, we really need to make sure that we do the best for our doctors as well. Thank you.
Thank you. So you have the chance to learn more about your country when you come to a place you even don't know. May I remind us that there is almost only a quarter of an hour left and we have 4 to 5 questions to answer. So this, I know calculation is not for every doctor, but this would mean 3 minutes for everybody. And the next one who applies, or on whom this applies, is Dr. Milan Kubek. The challenges of the doctor in rural area in Czech Republic were highlighted in the video, including long working hours and heavy workload pressures. What solution have you found on the national level, if you have solutions on the national level?
Thank you for the floor. It's a nice question, but it is not easy to answer this question. Just for explanation, I have more than 30 years experience as a doctor and approximately 19 years as a president of the chamber. And this situation is going worse. Because in the Czech Republic, of course, the people living in all the country pay the same insurance fee, pay the same taxes, but the gap between the availability of the healthcare in rural area and the big centers is widen and widen. Just to imagine, approximately each year we lost 1% of GPs and 3% of pediatrics. But 2/3 of this lost post are in the small cities or villages under 2,000 inhabitants. And generally, 15% of Czech people has not their own GP. Some of them don't like it, but some of them are not able to find any. And the problem is mostly in outpatient care. It's not only the GPs, but such very important branches, medicine like surgery or internal medicine. In outpatient care, more than 50% working doctors in surgery or internal medicine is over 60. And 1/4 is over 70 years old. It's a disaster for the future. And of course, the people are moving from the rural area to the cities. It's a process and we can do nothing against it alone. But there is some specific reason of these problems in the healthcare also. Because in the last 20 years, only one minister of the health came out from so-called university medicine lobby. All the ministers are former directors of the big hospitals or some professor from the universities and so on. And what happens? There's the economical preferences of the big hospitals. For the same procedure, the big hospital got more money than the small hospital. The system of the education after the finishing the school is also very good for the faculty hospital because junior doctors are obliged to spend months and months in university hospitals, and they are the cheap labor force for these hospitals. But these doctors are not in the countryside, in the small countries. And what we shall to do with this? Problems. Of course, there is no any miracle solution. First of all, we need more doctors. Yes, we need more students on the faculty of the medicine, but the problem is we have to educate them, but also we must maintain them in the system of the healthcare, mostly in the Czech Republic. Yes. And so a very simplification is we need to make medicine more attractive. It's a keystone. Otherwise, the junior doctors will not come. Otherwise, there will be no students study in the faculty of the medicine. Is it time?
Yeah. Thank you, Milan. We have another problem: the increasing. Yeah, Good applause. The increasing physical and verbal aggression from patients and their family that doctors face, and you in France are more or have been motivated to tackle this problem. So the question goes, as you can see, to Dr. Català. How did the French government address this issue, and how can the European countries work together to tackle violence against doctors, according to your opinion?
Yes, thank you, Chair, for the floor. Thank you for the Member of Parliament to invite us to express, and dear colleagues, we're all facing the same kind of problem all throughout Europe. And that's a problem that we in the CNOM, the French Medical Council, are working on, have been working on for more than 25 years now. We decided in 2002 to create an observatory of violence against doctors, and every year we published a figure and analyzed all these figures that are given to the press. And I totally agree with what you said about data. We need data to know exactly what happens, where that happens, why that happens, how can we face this, and that's exactly what we decided. 1 year later, we asked the government, our national government, to change also the law to get a higher penalty for people aggressing doctors. We now know that many publications, scientific publication, and thank you for the English, because I saw that in the British Medical Journal, that's almost 1 on 2 doctors face every year one kind of aggression, mostly verbal aggression, insults, but that's almost 1 on 2, which is a huge problem. And when we look at the figure of our observatory, we can show a trends, an increasing trends. Every year we getting more and more aggression. So that's exactly where we are. And the figure we are facing, we are observing in France are almost the same in all the European country. Spain also got as an observatory, really robust and with a lot of figures. They show exactly the same profile, but we still do not have any robust European system to collect data and similar data. So the European Council of Medical Orders decided 2 years ago to create this tool to collect data from all the different members. And we're hoping to have in the future some good analyzed, precise data to help. So what we did so we asked government to increase the penalty. We asked also for direct access to the police surgeon for doctors who want to file complaints. We also obtained to have the direct number of the police. We also get the panic button, the red button you can press if something wrong happened. And among many other solutions. We also create information about how to deal with violence when the situation with the patient becomes tricky, how to escape or how to deal with the violent situation. That's most of all what we did in the country. And probably I can give you some figure about what happens in France. It's a self-declaration process that we use to collect data. And we had last year more than 100 and 600 doctors that faces violent acts. 70% of that were verbal aggression. 10% of that was physical aggression. 6% lead to work interruption. So that means that you do not have any doctors for in that kind of situation. And so that's mostly the figure. And I know I've got only 3 minutes, so I may stop there and answer more questions.
Thank you. Yeah, unfortunately, and I guess this is a problem which is not restricted to health, but affects the whole society. So this is a sad development, but we need to do something against it. Before she gets in a hurry, we need to say goodbye to MEP Metz and thank once again for having us here. She needs to attend a meeting at 6 in Luxembourg with the European Commission, so she needs to run more or less.
Thank you.
Thank you.
good continuation to our
Thanks.
review.
Thanks a lot. We are continuing with the last question to the panel. Professor Bejovic from Slovenia, where the doctors have been on strike for over 1 year. And many have withdrawn the consent to work beyond the legal hour limits, exposing just how reliant the system has become on doctors' willingness to overextend themselves. And the government has, in response, tried to limit the doctors' rights to go on strike, as we have it also eventually seen in the United Kingdom. And how do the doctors react now?
Yeah, esteemed members of parliament, dear colleagues, many thanks for having me here. I am sorry that I have to describe a sad story, not a success story. But nevertheless, we can learn something from this experience. Indeed, we started with a strike now more than 1 year ago in January last year. It started as a real strike for a couple of weeks, and then it was transformed into an industrial action with the retract of the consents to work extra hours. That means more than 40 plus 8 hours a week. We do not have data how many doctors did this, but at the beginning, most of them did this. And but with the time, it became obvious that it is not possible to maintain the services with such limited work hours. We do suffer of lack of doctors in Slovenia for a long time. We have increased the number of doctors indeed in the last decades, but still we are lagging behind for 20% from European average. We are just below. And this limiting the working hours to European directive actually made life for doctors virtually impossible, because for the doctors who were in service at a given moment, the workload was too high and it was impossible to organize the services. So many doctors who retracted the consent first, they consented again to work extra hours just to kind of distribute the work among the colleagues better. It was the only way to go on. And not only, of course, because of the patients. And in the meantime, already in spring last year, now almost a year ago, the government decided to change the law regarding the industrial actions for doctors. That was quite stringent even before. Many services has to stay in place, and now which is the right to strike for medical doctors has been virtually abolished in the country. There's a long list of services that should be maintained, and this long list ends that actually any service should be done if its omission would harm the patient. So, at the moment, I must say that officially, formally, the industrial action is still in place, although we work kind of normally, just to keep the door open for the negotiation between the doctors' trade union that leads the industrial action and the government. So there are still some negotiations going on. Now, what does it have to do with the working conditions? Of course, the first thing is this law that prohibits doctors to strike. And this is something that is in a huge imbalance with other public professions, so making a doctor's profession less attractive, or making public health sector for doctors less attractive. It is a deterioration of working conditions per se. Then I've already mentioned this lack of doctors, and limiting working hours will mean higher burden, higher workload for doctors. Next week, we are expecting a new law in the country further limiting the rights of the doctors. The first thing are dual practices. Most of the dual practices in the country mean that a doctor who is employed in one hospital also goes and works in another hospital. also public hospital, just to replace this, to compensate for the lack of doctors. And not only that this possibility will be limited, the doctors who work elsewhere, and this is like 40% of doctors, will get less paid for the extra work in another hospital. And some of the doctors will decide not to work in a dual practice anymore because of the life-work balance. If you are not sufficiently compensated, then you decide not to work. So I cannot really imagine how the system will work in the future. And the third thing that is related to working conditions in general is that this long strike or industrial action, more precisely, highlighted that there is no dialogue in the country. There is not a dialogue between healthcare workers, especially doctors, and the government. The media started with a so-called stampedo on the doctors during the last year. So we were kind of blamed that we only work for money and so on. But I am happy to say that at the end, the public opinion on doctors actually increased because people see that we work hard and we try to provide the services. Thank you.
At least one positive message, because the other, it reminded me a little bit to Asterix, where there is with the Roman army, when they say that the vanguard has gone to the back to reinforce the rear guard. So you replace yourself finally. It's 3 o'clock, but there should be at least the opportunity for one question from the auditory. Who is? But if there is none. There is one, of course, please.
Well, first, we thank you, the organizing committee and the members of parliament who host this very important meeting. My question would be, first, a short comment that there is probably a shortage of doctors. There is definitely a shortage of doctors in specific areas of and specific countries. And even in the same country, as you described it very well, in the same country, there are places like district or distant areas, like in my country, Greece, that we have a greater shortage of doctors. As for the profession to be attractive, in my country, it's still attractive, the profession of medicine. However, most of them leave the country because of the working conditions well described previously. So I would ask the members of European Parliament and generally European Union, what could they do in order to motivate or probably to assist in improving these working conditions, probably specific funds going to unprivileged areas of the European Union, so as these doctors to have a motivation to go there? Is there a possibility for this? Is there a field that they could work on this? And definitely the close cooperation with our organization would be a very important thing. Thank you.
Yeah, if I may make a personal comment, because we have seen this in the discussion, limiting professional mobility and limiting doctors' rights may eventually, on the short run, help increase workforce, but on the long run, it's worsening the problem, and we should not do this, if I'm allowed to say that. And I would, at this point, like to close the discussion, thank the panelists, and then, yeah, we come to the discussion how we want to move forward, and we are very happy to have Maya Matthews here from the European Commission, and the floor would be yours now.
Thank you very much. Thank you for inviting me, honourable members, and for CPME to organise this. it's wow. I don't know about you, but I feel like my head is exploding from all of this, from all of the information that that we've heard. I've been asked to make a few comments on what I've heard, and just to say that I work in DG Sante, and I'm the head of the unit responsible for health systems, and of course the health workforce, as we've heard, is the backbone to that. We've heard the challenges. We've heard a lot about the challenges. I wanted to just mention two other challenges that might not have been so mentioned. We heard about the high job strain for doctors and nurses, which seems to be across the board, across the EU. And we heard as well about the uneven so-called medical deserts. Maybe what we also need to be aware of is the worrying trend about the decreasing interest in the medical profession from young people. It's been alluded to, but we actually have data. And we have this report that we publish every 2 years. It's called Health at a Glance Europe. And because of the importance of the health workforce crisis, we actually dedicated one whole chapter to the health workforce. And in this chapter, it shows very clearly the decreasing interest from 15-year-olds between 2018 and 2022 in the medical profession. So I think that is, I would actually like to start with that, because what I heard today was, yeah, what we know, that the population is aging. As a result, the health workforce is aging, but it's not being replenished by young people. So I think we all need, and here I wanted to end with this, but I know I don't have much time, but I want to actually give you a challenge as doctors, as leaders, as we've heard, as team leaders, about what do you think is needed to inspire young people to take on the profession. And maybe it's not just about even just higher salaries. It might actually be about what is the health system as we know it today, and what does it actually need. I was very happy to hear about the work-life balance being mentioned so much, that mental health now after many years is destigmatized so that people actually speak about mental health. And we are actually running with WHO a survey on the mental health of health professionals, and we will be very glad to share that with you once it's completed. I think we need to recognize that the health system as we know it, I must say I'm a public health professional. I studied public health 30 years ago in London, and there 30 years ago, we were told that we have to, stop the pyramid structure. We need to be more about primary care. We need to try to focus on prevention and health promotion. And where are we? Have we done that? Or are we still working with the same system that we had 30 years ago? So you understand then that young people, they come to doing medical school and they see their colleagues that are studying engineering or other things on a completely different plane. So I think that the whole way we need to approach the health workforce crisis and shortages is to look also beyond health. We have to look at how to attract young people. What are they interested in? As someone said, we need to ask them. I think it was a professor from Malta. We need to ask the young doctors, why are they leaving 1 year after they qualify? And then another challenge to you as leaders is please look after your nurses, because the situation is even worse with nurses. And we're working with WHO. We've just launched a new project with the EU for Health funding to really look at retention of nurses. We're trying to do quite out-of-the-box things, which is mentoring, but also trying to attract people mid-career. So now, from the times when you started a job at 20 and you did it all the way to retiring, the whole world of jobs has changed, and people feel much more happier to change jobs. So why don't we also find a way within the health profession to attract people mid-career? I think we need to be very flexible. We need to be a bit open-minded, and we need to try to find ways that might not initially be comfortable, because I know that the medical profession is very regulated, and as the professor said, we have to put quality and safety of patients first. But what I'm also hearing is that we are in a dire situation. and we need to, it's not business as usual. So we need to really find solutions that are coming maybe from other areas. We need to find ways that we can make medicine attractive again, as you said, you know, and that might be changing a little bit. We need to look at perhaps new allies that we didn't work with before. The whole area around digitalization. Young people feel very comfortable with AI tools. I haven't heard the word AI at all mentioned. I heard European Health Data Space, which will revolutionize things, but at the same time, as someone said, doctors are people. We can't rely on a platform, on an AI tool to do the job, but we need to also recognize that the whole health systems need to be adapted to what we're seeing today. So what we are doing in the European Commission, because I wanted to end on a hopeful note as well, is that we hear you very clearly about the data, and I want to give you a small anecdote about the data. We had very good data on doctors and on the age breakdown of doctors, but we didn't have the same for nurses. So when COVID hit, we could look at the doctors, but we didn't have that on nurses. So it took 2 years because, as you know, in the EU, to do things properly, it's a big tanker. But now we have the age breakdown of nurses. But this is thanks to our work with the Eurostat, which is the European Union's data collection. So I can tell you my team, and 2 of my team are here, we are always pushing Eurostat to try to get much more information on health workforce, because we completely agree with you that for you to go to your governments and to show them, you need to have that data. It's very difficult to get the full-time equivalents. We've asked, and I think even many countries don't have that data. So I think we need to actually try and find ways that we can collect this, because I think, again, if we're looking at a new way of health systems delivery, we will have to recognize that people will work part-time, and we have to factor that in. And for the planning and forecasting, we actually have a project ongoing, and CPME is part of that project, with 20 member states, looking at planning and forecasting tools. Because here I want to say, from the EU, this is where we can facilitate your work. This is where we can work together, and we have an added value, which is the jargon that we use, to come together to identify very good planning tools. And again, the planning should be for the health workforce of the future, not what we have now, but what our needs are in the future. So we're already doing that. The lead agency is Agenas from Italy. And then one more issue I wanted to also mention was skills, because that as well is something that I think Honourable Member Metz mentioned, the union of skills. So this is a priority. And so I would say what's very important, and here as well I turn to you, that we need to find for the health workforce, we might be more effective if we hook on to big programs, but just make sure that the health workforce is in there. So the union of skills is not sectoral, but we can use that to leverage the work on the health workforce. Attached to it is an action plan on STEM. Well, here we go. Here we can really say now how we can try to leverage that. And the last thing on funding, for those of you, you might not be aware of that, there is actually already a lot of investment of EU money that's going to health systems. Through the Recovery and Resilience Facility, 43 billion euro is going just to health systems. And from that, a large part is going to training for the health workforce. The cohesion funds as well, and this is what I think in Malta maybe you're referring to for the training needs. We are using a lot of cohesion funding for training needs. So it is there, but maybe our role collectively, and here I include myself in it, is that we need to sometimes raise our voices and connect the dots. And that's something that the EU can do. We can convene, and like you've done today, which I think is an excellent initiative, to bring together people, to find the commonalities, and then also identify the areas where we can work with you together. So thank you very much, and I look forward to continuing this partnership.
Thank you. Before our president will have the honor to give a closing address, there are a few minutes left for additional questions from the auditory, if there are some. Ray, please.
for the lady from the European Commission. We actually have those points in regard to AI in our AI document. The problem is all these issues are so vast that you can't cover them. You know, it would be great to have more engagement with the European Commission. So, for example, many of us overlap with different representative groups. At a UEMO meeting, we had the man from Eurostat, and basically his statistics are wrong in regard to Ireland, where I come from, and he acknowledged it, but he wasn't able to amend it. So, for example, what they've got is our general practitioners down as generalists. So it looks like we've got a lot of GPs when we don't have sufficient GPs. So it's at these type of meetings where we can clarify and correct things. It'd be great to have more engagement with the European Commission. Thank you.
Yes, Martin.
About AI, I think it's more about bureaucracy. That means, let's say our practice in Malta, certain patients are complex. I needed to open 4 or 5 databases. So we asked our IT system and our health service, please make us one dashboard where all I do is I want to see his x-rays. I want to see his blood tests. I want to see his previous admissions. So I think IT is helpful in unloading the bureaucracy. I think AI is still far away from providing safe patient care. I think it only has a role at the moment on radiology on little things, where the human eye is not good enough. But unloading bureaucracy is a very short-term measure which can help both the doctors and the patients. And IT, if used well, does unload. But unfortunately, many IT specialists who are commissioned do not understand the way the minds and the system works, and they create more bureaucracy sometimes rather than less. Thank you.
Unfortunately, that's true. I believe. Any other comments or questions? If not, Ole Johan, please.
Thank you very much, András. Thank you all for your valuable contributions today. I express our sincere gratitude to our host, MEP Kulja and Metz, for today's event. And far beyond this, their leadership and commitment to addressing these critical issues. We appreciate your engagement and the momentum that you are building at the start of the new European Parliament's mandate. We look forward to working closely with you to ensure that the European Parliament continues to play a leading role in tackling these health workforce crises. We also thank the European Commission for their contribution. As we conclude, I'd like to make a few reflections from what we have heard today. Firstly, in light of ongoing discussions around European preparedness and competitiveness, I want to emphasize that investing in the health workforce is investing in the resilience and prosperity of our societies. Retaining our doctors and other healthcare professionals is not only vital for public health, but also for ensuring that Europe remains prepared and resilient in the face of crisis. Healthcare professionals are the backbone of the entire healthcare system. Without them, there is no care delivery, no patient care, and no universal health coverage. As we saw with the COVID-19 pandemic, an ounce of prevention is worth more than a pound of cure. You see, we want the British back. We don't use the Système International. Well, strengthening our workforce today is essential to preventing future crises, reducing care backlogs, and ensuring that healthcare professionals can continue their work without being forced out by unbearable working conditions. We have heard the stories of doctors across Europe, which illustrates a health workforce on the brink. Secondly, the health workforce crisis is a shared European challenge that no country can address alone. European coordination is needed to ensure that EU countries are self-sufficient in training a highly educated healthcare workforce to meet their needs. This is not only crucial for the future of our health system, but also essential to safeguarding high-quality care for all Europeans. Addressing this crisis requires a coordinating effort across policy areas. And while we regret to see that the health workforce was omitted from the mission letter for the Commission for Health and Animal Welfare, we urge commissioners to work together to address the challenges facing the health workforce. That's why today CPME is calling for an EU health workforce strategy to ensure that this issue is given the attention it deserves at the European level. Finally, by being here today, you all show your commitment to tackling this crucial issue. We wanted to bring your voices and stories to European policy making, and this has been an important moment for that debate. The insights shared here will be crucial in shaping our next steps. We are committed to working together with the European institutions to ensure rescue our health workforce back from the brink. Thanks once again to MEP Kulja and MEP Metz and their team for making this event possible. Thank you, and I look forward to continuing this important collaboration. Before we leave the room, I would very much like in person to give a little gift to thank all the speakers. And outside this local, we would like to take a family photo before leaving the parliament. So if you have the patience to wait for me to give the gifts to thank all speakers, we take the photos afterwards. Thank you very much.
Thank you. I also want to once again thank our hosts. Silly Metz needed already to leave, Dr. András Kulja for having us here, and making even more parliamentarians realize that the health system and the health workforce is probably one of the key pillars of a democratic society and needs to be treated well. Thank you.